Hello, everyone. Good evening. Welcome to our Pediatric Epilepsy Conference. My name is Missy Dalloway, and I am the President and CEO of the Epilepsy Foundation Eastern PA. If you could take a moment and please complete this poll that just popped up on the screen, that would be wonderful, and then we'll get started in just a moment.
There's a little technical difficulty with the survey.
Okay, we can go ahead and get started here. So I will end this poll. So good evening, everyone. Welcome to our Pediatric Epilepsy Conference. Again, my name is Missy Dalloway. I am the President and CEO of the Epilepsy Foundation Eastern PA, and we are so happy to have you join us this evening. We have a fantastic program put together. We're really excited to learn together, and we're really excited to kick things off. You can go to the next slide, please. So just a few housekeeping items before we get started. Just so you know, your audio and video will be muted the entirety of the webinar. So you can go ahead and kick back and relax and just enjoy the program that we have planned for you this evening. The webinar is being recorded. So if you'd like to watch any of this again or share it with someone that maybe would enjoy watching it as well, this will be available after the completion of the program this evening. You'll see that there's a chat box at the bottom of the screen. Any questions that come up throughout the evening, please go ahead and enter those right into the chat. You won't be interrupting anyone. We'll hold all of the questions until the end of the presentations and ask them to our speakers at that time. And if you just want to pop in and say hello in the chat box, we love seeing that too. Next slide. So I know that there are a lot of parents and caretakers joining us on our webinar this evening. And first and foremost, we want you to know that you are not alone. Epilepsy is not as rare of a disorder as people often think it is. In fact, 1 in 26 people will be diagnosed with epilepsy at some point in their lifetime. I know that many of you watching might feel that you are the only parent going through what you're going through. Maybe you don't know other parents that have children living with epilepsy, but there are 3.4 million people in the US living with epilepsy. And in that number, it's 470,000 children. So if you are the parent or caretaker of a child living with epilepsy, you are not alone, and neither is your child. And we are here for you to create community and to connect you with other parents and other children going through the same situations, the same challenges that you are going through. And it's our job to talk about epilepsy and to create this community. And we have so many events and programs and resources and services that are available to you to educate you and empower you in your diagnosis or in your child's diagnosis. And we are here for you in navigating this diagnosis. Next slide, please. So a little bit about the EFEPA. Our office is located in Philadelphia, but we serve the 18 counties of Eastern Pennsylvania. So we go all the way up to the Scranton-Wilkes-Barre area, out to Lancaster, the Lehigh Valley, and everywhere in between. We have dedicated resource coordinators living and working directly in the community. And we focus on education, support services, resources, and referrals. We have a wide range of programs that are available to you. And more than anything, we are here to support you and help you any way that we can. Where the doctor's appointment ends, that's where we step in. And we're here for you as your patient advocate, your friend, and your partner in this fight against epilepsy. Next slide, please. So on the screen here, we have a few of our programs and services detailed, but this is really just a snippet of what we do. I definitely want to recognize or kind of spotlight our seizure recognition and first aid trainings. So our resource coordinators will go into your child's school to train the teachers, school nurses, personnel, the students in seizure recognition and first aid so that your child can be in the school and feel safe. And you have the peace of mind in knowing that your child's teachers and school nurses know how to recognize the different signs and symptoms and how they can respond and help your child should they have a seizure in the classroom. We also offer monthly support groups all throughout our region. Those are currently being held virtually. I definitely also want to bring special attention to the fact that we host a parent support group. So if you are tuning in this evening and you are the parent or caretaker of a child living with epilepsy, we have a really great space for you to connect with other parents that are going through similar challenges. You can share your experiences, share your resources, just a really great group to connect with other parents. And I definitely encourage you to tune in and get involved. We host a wide range of community building and awareness events, such as our Walk 10 epilepsy events. We have two coming up this June, June 13th in the Lehigh Valley and June 19th in Philadelphia. We host two walks in October in Lancaster and Northeast PA. We offer educational conferences and webinars all throughout the year, such as this one that you're tuning into this evening. A wide range of information and referrals, medical, mental health, legal referrals, a wide range of youth and young adult services. Our resource coordinators will meet with you one-on-one to help you with IEPs and accommodations and seizure action plans. We host a monthly Youth Achieve meeting, as well as retreats and camps. So the weekend of Friday, May 21st to May 23rd, we have our young adult retreat, and then our Camp Achieve in August. And that's a week-long camp for children ages 8 to 17 living with epilepsy. So again, if you have a child living with epilepsy, a really wonderful way for them to meet other children living with epilepsy. And it's just a really magical place. And we definitely would love to have your kid involved. So next, I wanted to take a moment to give some really special thanks to our corporate partners. Our corporate partners are really the ones that make our work possible. They support us and our programs and events, and they really help make sure that we can reach our folks living with epilepsy and support them throughout their diagnosis. So first and foremost, I wanted to give an extra special thanks to Greenwich Biosciences. They are the presenting sponsor of our entire conference and webinar series this year. So they have given us that support across the board. Really grateful to them in all of their generosity. So I wanted to next pass the mic to our friend Jen Cesaretti for her to say a few words.
Thanks, Missy. Hello, everyone. My name is Jennifer Cesaretti, and I'm honored to be speaking to you, especially in this virtual world today, on behalf of Greenwich Biosciences and our entire team. As a sponsor of the first ever Pediatric Epilepsy Conference, Greenwich Bioscience is proud to partner with the EFEPA for events like this to help people stay connected in this virtual environment. We are united in what we're trying to accomplish here. And today, to raise awareness to epilepsy and to have a positive effect on care and on the research and on the lives of those who are impacted by seizures. You may know us best by the company researching and delivering FDA-approved cannabinoid medicines to help address serious conditions, but also know that our focus is you. Patients and families are at the center of everything we do. And we really strive to make a positive and meaningful difference in all of your lives. And we're really grateful to be here. So thank you.
Thank you, Jen. Next slide, please. So next, I wanted to take a moment to thank our conference series sponsors, ASI and UCB. ASI and UCB have sponsored our conferences, our 5 conferences that we hosted this year, including our Pediatric Epilepsy Conference this evening. Next slide. So I wanted to invite Nicole from ASI to say a few words, please.
Thank you, Missy, and thank you for the opportunity to be here tonight with you all. Hello, everyone. My name is Nicole Alessino, and I'm a Neurology Integrated Care Manager for ASI. Thank you for the opportunity to introduce our company. At ASI, Human Healthcare, or HHC as we call it, is our goal. We give first thoughts to patients and their families and helping to increase the benefits healthcare provides. As the US pharmaceutical subsidiary of Tokyo-based ASI company, we have a passionate commitment to patient care that is the driving force behind our efforts to discover and develop innovative therapies to help address unmet medical needs. To learn more about ASI, please visit us at www.eisai, thank you for that, .com/US, and follow us on Twitter and LinkedIn. And I look forward to seeing folks at Lehigh, the Walk in Lehigh on Sunday. I'm giving you a little plug here, Missy. I think that's June 13th, as well as in Philadelphia on Saturday, June 19th. Thank you.
Thanks, Nicole, and thanks for that plug.
You're welcome.
So next, I wanted to invite our friend Mindy from UCB, our other conference series sponsor, to say a few words.
Hi, everyone, and thank you, Missy, for including us in the EFEPA's Pediatric Conference. This not only includes all of the people living with epilepsy, but we want to welcome all the families and caregivers who stand by you and support you every day and who are themselves affected by epilepsy. Again, my name is Mindy Reibstein, and I work for UCB, where we are inspired by patients, driven by science. Every day, one of our priorities is to improve the lives of people living with epilepsy. Together with you, we refuse to let this disease get the best of us. UCB continues to partner with organizations like the EFEPA, and we are so happy to work side by side with this organization and all of you so that together we can overcome epilepsy. At UCB, we strive every day to work for people living with epilepsy through science, education, and advocacy. We recognize you, the courageous fighter, and those that support all of us in sharing your cause. Know that we are at UCB here to support you through your journey. Thanks.
Thank you so much, Mindy. Next, I wanted to take a moment to thank our vendor sponsors who have sponsored the Pediatric Epilepsy Conference this evening: BioCodex, Neurelis, and VNS Therapy by LivaNova. And I would like to invite our friend Julian from Neurelis to say a few words.
Hi, Missy. This is Julian DeLeman. Can you hear me okay?
Yep, we can hear you.
Oh, great. I'm the territory manager in Philadelphia for Neurelis. Neurelis is an innovation-driven neuroscience company, and we're really excited. We're meeting unmet clinical needs. Specifically, we have a nasal product that we've brought to market that helps people and potentially can replace some of the rectal medicine. So we're really excited to be able to share that with your audience tonight as well. We're committed to helping improve the lives of patients with epilepsy. We're thrilled to be partnering with the Epilepsy Foundation of Southeastern Pennsylvania tonight. We thank you for allowing us to participate in this event, and we're pleased to be here. Thank you so much.
Thank you, Julian. Next, I wanted to introduce our host of the Pediatric Epilepsy Conference this evening, our very own Lehigh Valley Resource Coordinator, Ellen Baca.
Hi, everybody. Thanks for coming this evening. I just wanted to go through, they were already mentioned, so I just want to let you know in 2 weeks we have a adult epilepsy conference on Tuesday, the 25th. Some really good speakers there. And we have a young adult retreat coming up May 21st to the 23rd. Everything's COVID friendly, so we do a little bit of in-person and a little bit of virtual, so you can look at our website for that. And as everyone discussed before, we have 2 walks to end epilepsy coming up, one in the Lehigh Valley and one in Philadelphia. Very excited about that. And finally, we have Camp Achieve in the middle of August. That's for kids with an epilepsy diagnosis between 8 and 17. Kids have a wonderful time. They get to meet lifelong friends, and so you can also check that out on our website. Here's the schedule for this evening. We're going a little bit over, but so our next speaker is Dr. Sheikh, and we hope to end at 8, but you never know. So let me introduce Dr. Sheikh. He's been a pediatric neurologist for more than 27 years. After receiving his medical degree from Dow Medical College in Pakistan, he completed his internship and residency at Brookdale Hospital in New York. After that, he completed a fellowship training for pediatric neurology at the University of Minnesota. Dr. Sheikh is board certified by the American Board of Psychiatry and Neurology with special qualification in child neurology. So I'm going to unshare my screen and have Dr. Sheikh share his screen, and he can begin.
Share. Loading. So, can people see my screen?
It's you want to put it in the slideshow mode. Starting, you're not exactly at the beginning, so.
It's not moving.
Don't forget, everyone, if you have any questions, put it in the chat box down at the bottom, and we're going to monitor those questions and ask Dr. Sheikh at the end of his presentation.
Okay.
Looks like our PowerPoint's frozen, of course.
Of course.
Yeah. So yeah.
Don't worry, I still have it here if you want me to do it from here.
Okay, if it doesn't work, we'll have to, I don't know why it says stop. No, let's stop sharing live. New share.
Do you want to do that, Dr. Sheikh?
Let's see. Okay, we may have to.
I'll pause sharing for 1 second. I'm gonna restart the PowerPoint.
Just give me 1 minute and then we'll see if it works. Otherwise, share.
I wish I had some elevator music to play right now.
It's working now, right?
Good. And
So
There you go.
can everyone see the
Yep.
screen, and
Yep.
can you hear me well also?
Yep.
Okay. So thank you very much for inviting me here in the Epilepsy Foundation. Special thanks to Alan Barker and Missy for putting all this effort to accomplish this. So we'll get quickly to our talk, because one thing I can tell you, it's an only 1 hour talk, and epilepsy in 1 hour, finishing the entire concept of it, I think it's a very short time, but we'll try our best to see how much people can understand. So one of the things I want to tell you is that epilepsy is not a new disease. If you look at the literature, even in the initial written script in the Akkadian era, which is around 3,000 to 5,000 years ago, there were scripts that you can see which had talked about the description of the events that we now call seizures. And the history is not only limited to the Egypt, but from China, Babylon, around the globe. You could see some of the writings and things that depict that these individuals knew that there was something abnormal, though the understanding of these events was very different than what we think about epilepsy now. In 400 BC, the Hippocrates called it a sacred disease. It wasn't until late 1800s when Dr. Jackson, who's a neurologist, first came with the concept that this is a disorder of brain electricity. And I see that since then, I think there has been explosion in our knowledge. Initially, it was the clinical knowledge that we said that this is what the seizure would be. And the way the seizure is described is, it's like any feeling in anybody. It may be a movement, or it could be some smell or sensation. If it is associated with an abnormal electrical discharge in the brain, then it is called a seizure. If it is not associated with these symptoms associated with any electrical discharge in the brain, then it is not a seizure. It is just an individual, his feelings that you can describe. And it is important concept to understand, because everybody goes through different feelings at different times. And that does not mean that they're seizing. So epilepsy for ages, and even to date, we describe as it's a brain disorder that in an individual has a tendency or is predisposed to recurrent unprovoked seizures. That means for no reason they will develop some abnormal event, which could be in terms of their movement, or it could be in terms that they're feeling something, they're smelling something, whatever it may be. The new concept is, it's not a brain disorder, but it's actually a brain disease. It doesn't change from the disease point of view. The word they use, disease, now is to emphasize more that there's a condition that should be taken seriously, both in terms of research as well as in terms of management. So the new concept, before we said if somebody you can tell has a tendency of recurrent unprovoked seizures, that means seizures that happen without any reason. And if somebody had 2 seizures, we would say, oh, you have a tendency of having a seizure, so you have epilepsy. If you had 1 seizure, we would not call you as being epileptic. We would just call it as a seizure. So according to our new concept, or the new definition of epilepsy, is that if somebody has 2 seizures which are unprovoked and occur more than 24 hours apart, we can confidently say, oh, you have an epilepsy, or you have a high chance of recurrence of the seizures. However, if you have 1 unprovoked seizure, and I can say that your chances of having another seizure is greater than 60% over the next 10 years, then I can still say that you have epilepsy. And we'll go more into this lecture and talk that how can we say that your risk is greater than 60%. Or you can call somebody as having epilepsy if they have one seizure, but you can put their epilepsy into a particular syndrome. And I will talk more about how do you place somebody's epilepsy into an epilepsy syndrome. So I think this is the new concept. Therefore, you can make a better judgment as to, even after a single seizure, that you want to start the patients or you still want to wait and see if they're going to have another seizure. Having said all this, it tells you that how ignorant we are despite our great knowledge about epilepsy, that we can't give you a straight answer. So as Missy had already introduced you, that it is a worldwide disorder. There are about 65 million people in the world. The incidence is about 0.1%. So every year we get 150,000 new cases. Its prevalence is about 0.5 to 1%, which is about 3.4 million people living in US who have seizures. It has a great economic burden, about $28 billion. And this does not include the indirect costs to the people or to the country. Another unique thing about epilepsy, it has a bimodal distribution. What that means is that we see a higher cluster of children having seizures, and then the second higher cluster is towards the older age group. So the young adults generally don't start with seizures, though they can, but the incidence is less. But in children, it is relatively higher. Usually boys and girls are affected equally. So before we go on, I think there are two things that you need to differentiate. One is what is a seizure, and the second is what is an epilepsy. So let's talk about what is a seizure. So I can tell you a little bit of the history that before we knew about seizures in the beginning, late 1800s and early 1900s, the neurologists who were interested in these episodes, they had these fascinating people who would come and tell them, oh, I have these symptoms, and this would go along. And so there was a whole collection of different symptomatology. So in 1960s, they said, let's sit down together and try to see what these are, because every neurologist called seizures differently. So they named them different, they expressed them different, so there was no systematic classification. In 1980s, anatomical based classification was thought of, and it was like, well, somebody's got temporal lobe seizures, they felt seizures are coming from the temporal lobe. But it wasn't until 1985 when we developed our first seizure and epilepsy classification and classification of epileptic syndromes. And after 30 years, we just in 2017 revised it. And I thought it's something that would be it would be important for people, especially family members, to know, parents to know that it's changes in verbiage. The underlying condition has not changed. It is the same condition. As we have developed more and more knowledge, we are able to better classify them. We have more understanding of seizures. So this was the easy classification, which I grew up with learning, that seizures are either partial or they're primarily generalized, or we cannot tell what they are. A partial seizure was that would start in one of the areas of the brain. The generalized seizure was it activated the entire brain, both on the right and left side, and the person just passed away right at the onset of the seizure. And in the unclassifiable one, there were some, you couldn't tell where the seizure was coming from. So, so this was in a nutshell, partial seizure, generalized and unclassifiable. So in the partial seizures, people said you have simple partial if you were completely alert, awake, and you know you were having a seizure. In complex, you're kind of confused, disoriented, and you didn't know what was going on. And any of these could, secondarily generalized. And then there were different types of generalized seizures like absence seizures and myoclonic, tonic, atonic seizures. So in 2017, some of the neurologists sat down and said, well, partial seizure is not like a half a seizure or 3/4 of a seizure. It is a real seizure. It's called partial because it has a focal onset that starts in certain area of the brain. So depending on which area of the brain it starts, you are going to get that symptomatology. So if it starts in the area where somebody has smells, so that you're going to get what we describe as an aura starting as smell. If it starts in your occipital cortex where you see objects, then you can have visual hallucinations and some visual symptoms, flashing lights and a variety of complex symptoms. So the simple seizures, the simple partial seizures, let me go. So simple partial seizures are technically focal onset seizures in which you're completely aware of what is going on. In complex partial seizures, you're not aware, you're confused, you're disoriented. So that's the new terminology is focal onset with intact awareness or focal onset with impaired awareness. And these seizures, either one of them can, then become generalized. They would spread to the brain and then become generalized. And then you have motor or non-motor. Motor means that there is a movement of the body part. Non-motor is more like autonomic symptoms, emotions, feelings, confusion, disorientation, staring, spacing. So those are the phenomena where you don't see the grand mal features of the twitching and jerking, but you see the other phenomena would be the non-motor. And same is true for generalized onset epilepsies, where you can have absence with just staring, which would be a non-motor seizure, and then the jerking type seizures, which would be your motor seizures. And the ones which are unknown onset are that many times what happens is a person may be in a sleep and he may have a he may have a seizure that starts in one area of the brain, and then it generalizes, but nobody witnesses it. So it is very hard to tell if it is focal onset or it is generalized onset. So now they made it easier in the classification. They say it is just say unknown onset. So I think it has made life much easier and more clear and to the audience to know how to classify the seizures. So this is just the simplified version of it. And this is a little same simplified version, but gives you more description of different types of phenomena that you can see in different types of seizures, which I talked a little earlier. So this is the slide that I made maybe over 25 years ago from the textbooks and things like this. So when I learned seizures, 65% were idiopathic. And then about 2.5% were related to infections, like if a child had meningitis. 5.5% were like they were involved in accidents. Somebody had a fall, they had bleeding into their head, and that resulted in seizure. Neoplasms are relatively rare as a cause of seizures and only accounted for 4% and still account for about 4%. Then malformations of the brain, these are developmental malformations of the brain, which accounted for 8%, and vascular ones were somebody had a stroke or bleeding into the brain, so they accounted for 11%. And the others, what we call genetic or metabolic or neurodegenerative diseases, which are rare but do occur in childhood, accounted for a small percentage of the seizures. So the new way of thinking about the etiology of seizures is either it's a structural cause, it is a genetic cause, it is a metabolic cause, it is an infectious cause, or it is an immune-mediated cause, or it is an unknown cause. So we don't say idiopathic anymore. We say it is an unknown cause, and this is a moving target. So every morning you can wake up and they'll find a new genetic mutation and they link it, oh, this person can also have a seizure. If they can't find, they find a mutation, but they don't know what it is, they keep it in their database, and 5 years from now, if somebody else has a similar mutation and he also has similar symptoms, then they can say, oh, this genetic mutation is also linked to seizures. Among the structurals, it was the same, whether it could be tumor, it could be hemorrhage, it could be abnormalities in the brain. So it could be any structural reason behind. Genetics is very interesting in epilepsy because a variety of different types of genetic conditions, which could be single gene mutation that can cause seizures, or which could be complex chromosomal mutations that can cause seizures. In many of these, there are other syndromes, and seizure is just a part of that syndrome, but there are some specific single gene mutations in which epilepsy is the main manifestation of that mutation. Another concept I think is important for people to understand is a concept of epileptic syndrome. So what it is if you can classify a child's seizure in whether it is focal onset or generalized onset, and you have a special EEG signature for that particular type, and at a particular age of that child, you can better predict that what this epilepsy syndrome is and what would be the better medications to which it's going to respond and what the long-term prognosis is going to be. And I'll give you a few examples to clarify this. So let me give you an example of a child who is, say, like 3 years old, 4 years old, and has a seizure. He wakes up in the morning, comes to his parents, he looks a little scared, he cannot talk, his mouth is twitching to one side, and he's drooling, but he follows their commands, and it lasts for a few minutes, and then he goes back to sleep. And if we do an EEG on him and we see the EEG shows some sharp waves coming from the central temporal, mid-temporal region, so this electrical signature in this child with this type of focal onset seizure will tell me he has got most likely benign childhood epilepsy with centro-temporal spikes. And I can say with confidence, oh, the prognosis is going to be very good for this child. He's going to respond very well to the treatment. And even if you can tell with confidence that this is what the case is, you don't even need an MRI, because you know this is one of the genetic types of epilepsies and it's going to respond to the medications. Now, let's take another example. So if there is a teenager who comes with a generalized seizure, and when I talk to him, they say, oh, my body has these twitches and jerks, and oh, my grandfather also had it, and I do an EEG, and the EEG shows what we call 3.5 to 6 hertz generalized spike in wave discharges. I would say that this electrical signature, oops, in this age group, in this age group with this electrical signature and a positive family history, that this child most likely has juvenile myoclonic epilepsy. And if I can make the diagnosis, again, I can tell you there's nothing wrong in the brain. It is an epilepsy which can be autosomal dominant, and that it does respond to the medications, but the treatment will be lifelong because 90% of these individuals will have lifelong seizures. And the response to the medication is good. Let me give you another heartbreaking example. If there is a young infant, 6 months old, who comes with some brief epileptic spasms or brief jerks, and I do an EEG on that person, and it shows what we describe as hypsarrhythmia, very abnormal looking EEG, then I would say the This condition is infantile spasms, now also called epileptic spasms or West syndrome. And understanding that that feature is important because I know this child's prognosis is not going to be good and will need a lot more aggressive treatment. And the treatment of choice would not be our regular seizure medication, but some hormonal therapies with adrenocorticotropic hormones, though there are some medications like vigabatrin which can help them. So giving you these concepts, I think understanding these concepts is important in assessing an individual. Now, the second thing is, how do we manage seizures? Obviously, first you have to make a diagnosis and then you will go on to treat them. Before you make the diagnosis, you have to make sure that this is a seizure and that this is not a seizure. And the reason I say that sometimes children can have night terrors and they can be very scared looking. Boy, it may be very difficult to differentiate just based on clinical symptomatology that these are seizures or whether they are night terrors. Though there are certain unique features to night terrors and a detailed history may clear that, but sometimes as neurologists, we do end up monitoring them to be certain that these are not seizures. Some people with headaches will get confused and disoriented. Some people have syncopal events where they feel they're going to pass out and some actually do pass out. And we have to make sure that this is not a true seizure. Some people who have seizures also have non-epileptic seizures, which we call pseudo seizures. It may be underlying anxiety, it may be underlying fears, or other reasons in their environment, which may lead them to have non-epileptic events. And these can certainly be very challenging. Breath holding spells is another one in children where they will try and hold their breath and then pass out. Some children will have some aggressive outburst of behavior or panic attacks where parents will say, oh, this happens suddenly and the child looks red, and then this happens for 15, 20 minutes and then he's exhausted. It sounds like what we used to call complex partial seizure, or before and now seizures with impaired awareness, but these are not seizures. So our EEG signature for them is not present. Now, the second important thing is, how do you diagnose? Obviously, history is the most important. Somebody who's seen the event is going to be the person who will be able to describe you, is the most important person in making the decision whether this is a seizure or not. Easy for me to say, but very difficult, because most of the time the initial onset of the event is not known, or this person himself may not have any recollection of the event because they pass out, they are unconscious. Physical exam, especially in children, is important because sometimes the skin may give you some signatures of there's another type of syndrome that has seizures more commonly associated with them. Can give you example like tuberous sclerosis and other neurocutaneous syndromes, which we call like neurofibromatosis. We'll often get basic electrolytes, glucose, and drug screen because low glucose or low sodium can also give rise to seizures. EEG is a very commonly used tool, and video EEGs we do very commonly. Most of the children, unless you can say it is a clearly genetic epilepsy, will require an imaging study of the brain to rule out any structural abnormalities. And then genetic testing. Genetics testing is expensive. Most of the insurance companies do not pay for it. And their argument is that will it alter your management? However, with more and more knowledge coming up, and I think this is something that eventually will become more and more common, and especially in epilepsies which are resistant to treatment, or if somebody has another associated condition associated with them. So there are new advanced diagnostic tools. Corticography is a very invasive procedure where you would open the skull and do the EEG directly on the surface of the brain. We have functional MRIs of the brain where you can have a person move their arm or leg and see what part of the brain they're getting activated. A SPECT is another, you inject the dye and soon after the EEG and see how is it taken up during the scanning. PET scan similarly. The most recent among our diagnostic tools is the magnetoencephalography, which was just approved last year in 2020. It's basically what they do is they assess the magnetic field in that abnormal firing neuron or the group of neurons in the brain. And it is very specific, and it really localizes the abnormality very clearly. It is not needed for assessing general epilepsies, but once you prepare an individual for epilepsy surgery or invasive procedures, I think it plays a big role in getting a more accurate localization for the lesion. And magnetic source imaging is another new technique where they'll superimpose on this magnetic imaging of the brain, the MRI, to find exactly look like what the brain looks like. Second step, we come to the management, and the management, obviously, when somebody has seizure, we talk about general counseling, the precautions and regular things. And then we have to make the decision, should we treat or should we wait to see if we have another seizure? And then among the treatment modalities, we have seizure drugs, we have choice of surgery, we have choice of ketogenic diet, we have choice of neuromodulation. And then I think treating the patient is the most important thing, because seizure is only one part of a person who has the seizure. It often comes along, especially in pediatric age group and even in adults. There are a lot of other challenges in life. You know, parents who have children, they probably face this every day. So many children can have problems in school, can have problems with emotions. So all this has to be treated as a whole when you consider a child with epilepsy. Among the general seizure counseling, obviously it is age appropriate. So if somebody is going to drive, you're going to say, oh, you had a seizure, you cannot drive. If it's a younger individual, you have to make sure they're not run by themselves along the pools. So it's going to be all common sense thing that if somebody has a seizure, that would not injure the individual. We generally counsel them what would be the best first aid for seizures. And then we have seizure rescue medications. And then very recently, Embrace by Empatica was devised, is the first seizure detection device that was approved by FDA in 2018 for children over 6 years, I believe. They wear it like a watch, and it does sense the EMG and the shaking activity in an individual. Then it automatically calls parents or whoever is the individual that they have assigned to respond. And I feel it's helpful because children can sleep on their own, and if they have a seizure during sleep, parents would run to help the kids. I think I have seen this, at least in teenagers and other anxious families, to be very helpful. So decision for treating obviously depends what is the risk of the next seizure. In general, if somebody has a seizure, the risk of next seizure is 35%. If they have 2 seizures, it's about 60%. And most people will agree that after a second seizure, they should be treated. Now, as you saw in our initial slides, that if you can diagnose somebody as epilepsy syndrome, then you can make the decision, or even after the first seizure, it needs to be treated or not. Obviously, if there is a structural abnormality, tumor or hemorrhage, then that has to be addressed. And is there a possibility of genetic disorder? So those are all the questions that we as neurologists have after a seizure. as well as the parents, because the most important thing to the parents is, why did my child have a seizure? And this is just the recurrent risk that if somebody has one seizure, the chances that you'll have a next seizure, 50% of them will have it within the first 6 months. So, and about 50% will have them over the next 2 to 3 years or even 8 years. So that's why we say, you know, take extra precautions for at least 6 months after the first seizure, because we don't know when the next seizure is going to happen. Let me quickly run down these seizure medicines because running short of time. So the initial medicines were the bromides, and then in 1912, phenobarbital was introduced. We still have it. And 1970, the valproic acid was introduced. So for decades, we only had these choices of the medications to treat seizures. In the era of the decade of the brain, which was the 1990s, we had about 13 or 14 new seizure medications that came to the market. And in 20s, we had about 7 or 8 seizure medications that came to the market, in which included the cannabidiol, and the fenfluramine was the last one in 2020. Seizure rescue medications, 1997, FDA had approved rectal diazepam. And after almost 30 years, we've got the intranasal versions. And the most latest one in 2020 was the Valtoco, which was the intranasal diazepam. I think it's really helpful in older children because of obvious reasons. So mechanism of action. I think this is something that is beyond my understanding, but what you will see is sodium channels are involved, potassium channels are involved, calcium, GABA, AMPA, glutamate, or we still don't know. Interestingly, if you see a sodium channel is involved, these are the ion channels which regulate how much sodium is going to go in, how much potassium is going to come out of the cell, and when it goes in and out, it generates electrical current. So if there is an abnormalities in these ion channels, then you potentially can have seizures. You have chemicals in the brain, and they can be abnormal and cause extra stimulation to the brain or decrease inhibition, and that can lead to a seizure too. So these are some of the seizures. Now, someone asked me, how do we decide what medicine to use? So we have certain medicines which are good for focal onset seizures. We have certain medicines which are good for generalized onset seizures. And then there are broad spectrum seizure medicines which can use that we can use if you don't know what the onset is, whether it could be focal, could be generalized, because these medicines can work for both different types of seizures. Side effects of the medications. Majority of the children will tolerate the seizure medications well. However, nausea, vomiting, dizziness, fatigue, they are not uncommon side effects from seizure medications. If they are in toxic doses, you can get double vision. Some can have allergic reactions. Some medicine cause weight gain, some cause weight loss. Some can have tremors. Some can have more predominant behavioral side effects. Again, does not mean that every medicine is going to cause in every individual. Maybe 10 to 15% of them will have significant side effects. At what point you will make a decision, or let's change to a different one. There are some idiosyncratic reactions where you can have suppression of your bone marrow, you can have liver toxicity, you can have Stevens-Johnson type allergic reactions, you can have pancreatitis. So these are some of the serious side effects in which you cannot use the medicine again if an individual develops these side effects. So we generally warn parents that if you have these side effects, stop it. I think this is a very important slide that I want to share with you. This is the slide that I made almost 25 years ago, and this hasn't changed. We have so many new anti-seizure drugs. However, when we use the first drug, 50% respond. If we add a second medicine, another 11% respond. If we add a third, another 4% will respond and they won't have seizures. But no matter what you do, another 35% will not respond to the anti-epileptic medications. And we call this group as refractory epilepsy, medically treatment-resistant epilepsy. So these are the ones which are a big challenge. So once you have a refractory epilepsy, you have choices. You have a non-invasive choice of ketogenic diet, and you have invasive procedures in which you can do epilepsy surgery, or you can do neuromodulation. And I'll talk a little bit more about it. The first device for neuromodulation was the VNS that was FDA approved in 1997. Then in 2013 was the next device approved, which was responsive neurostimulation, and deep brain stimulation was approved by FDA in 2018. So we had a big hiatus from 1997 to 2013 from having another neuromodulation device. So epilepsy surgery, if you have focal seizure, you can take that part of the brain out and you cure the epilepsy. If the seizure rapidly generalizes and somebody's having a lot of drop attacks, you can split the brain into two halves so that the seizure doesn't spread. And they may not have a big seizure, but they will continue to have small seizures. There are certain conditions in which one side of the brain is not well developed and produces a lot of seizures. And if you remove that part of the brain, surprisingly, the seizures are much better and the individual develops much better. And the most latest among the treatment options is the thermal ablation. This is called laser interstitial thermal therapy. So what this is they put a probe right into the part where the seizure is coming from, and they burn a small part of the brain under magnetic observation, and about 50% of them do respond to it. So VNS is the vagus nerve stimulator. This is the device that's placed into a skin under the chest, and wire goes and wraps around the vagus nerve. And then deep brain stimulation, the device is similar, but the wires put into the deeper part of the brain. And in responsive neurostimulation, actually the device replaces the small part of the skull, and the electrodes and the probes go directly into it. And the unique thing about this is it also reads the electrical seizure arising, and at that time it'll give you an extra electrical current. So this was the first device approved in 1997, which was the vagus nerve stimulator. And how we modulated was we had a little Palm Pilot. Now we have a lot more sophisticated iPads to control it. It's wireless now. It used to be with a wire, and you just hold it and control the settings through radio frequencies and adjust it. And surprisingly, about 50% or 60% of people had about 50% reduction. This was the RNS. So you replace the device, a small piece of the skull with this device, and the wire goes inside the brain and gives electrical shock once it reads that the seizure is coming. Deep brain stimulation, the probe goes right deep into the brain and gives electrical stimulation where it sets off a rhythm to cause a seizure. Now, with all this, to tell you the new definition, when can we say the individual seizures have resolved, is if they have no seizures for 10 years and they have been off medicine for 5 years, or if they had one of those childhood epilepsies that resolved at a certain age. And I told her, like benign Rolandic epilepsy, it starts around 3 to 6 years of age, or maybe it can start earlier, but by 16, 18, or the most 20 years, it'll go away. So if you want to stop the medicine, you can. So in conclusion, epilepsy is not a single disorder. And I think this is the most important thing for people to understand, that you cannot say, oh, my child has a focal seizure disorder, a generalized seizure disorder. And to give you an example, I was telling you there are sodium channels. When we discovered these sodium channels, we thought we had the answer, and we'll say, oh, you have this abnormality, and we found the gene for it. But then we saw clinically these individuals do not behave the same way. Some have terrible seizures and some don't have terrible seizures. And then it turned out that the DNA that makes that sodium channel already has more than 40 mutations. The last time when I reviewed the literature, there were 40. They're probably more than 40 by now. So that means if there is a different mutation, it may not behave the same way as another child with similar sodium channel abnormality would behave. So sit tight, and I say always be optimistic. The genetics is really evolving and making us understand better at the molecular level how seizures are generated. We do have a lot more treatment options. Unfortunately, the refractory epilepsy still is 35%. However, I think quality of life is much better because if one medicine doesn't suit one, we have a choice of trying another medicine. I think I'm hoping for development of the target specific therapies, once we know exactly what the genetic defect is, and then we can target special medicines exclusively for that particular individual. I think that would be the fascinating area for the child neurologist and to manage the seizures. So thank you for listening. I'm not sure if I sorted out some of your concepts or did I confuse you even more, because this topic is very extensive. And I think 1 hour is really not enough time to go into the details.
Thank you very much, Dr. Sheikh. There has very good presentation. I enjoyed it a lot. There's just a few questions. Someone wrote in that one of the triggers for the child is hyperventilation. They had a few episodes during the year. They have a VNS. What kind of sports would you recommend for them? Like would cross country be out of the question?
So one of the things, if the child has absence, so most likely this is an absence type epilepsy. Interesting thing would be to see, is sitting down and hyperventilating causing seizures, or if he's running and playing around and he still gets the seizures. Because in my experience, these are two different things. He can have a seizure, but does not necessarily mean that if he's running and hyperventilating and he will have a seizure. I think it may be, I don't know the reason behind it, but it may be related to some electrolyte changes, which when you just sit down and hyperventilate versus when you're running and you already have acidosis and you're hyperventilating. But yes, so if he does run around and he has more seizures, then you should have restrictions on it.
Great. Someone asked, the seizure detection device that you talked about, does it pick up on non-convulsive seizures during sleep? They have a child that has complex partials. They have a video monitoring system in her room, but she's getting into puberty. She wants her privacy. And they're just I think she's kind of looking for ideas. So they monitor because they're waiting to see if there's any change in presentation.
So a nice question. The answer is for the complex partial seizure, sometimes they can still have some movement. So if it picks up the movement and the EMG activity, it will pick up. But if it is something like an absence seizure, it is, I don't think that this would be appropriate. However, I can tell you there is a lot going on, and Apple and other products are coming up which may be picking up some of the spread of these electrical activities and trying to get these other type of electrical signatures rather than movement signatures. So at the present time, I don't think that these devices are picking up what my understanding is on the subclinical type of seizures. Complex partial, they may still, because there's going to be some odd movement, they still may have some EMG activity that increases. But they were right. I mean, it is not the same as the grand mal. On the other side of the story is if somebody has an absence seizure, it's not going to be as life-threatening as would the general generalized tonic-clonic, where you can stop breathing and aspirate and those type of things.
Great. Those were the only two questions. I would say to the person that wrote that question, if you contact us at the foundation, we have come across a few apps and things like that that might help you. Just give us a call, any one of us, and we'll be glad to help you with that. We're going to have to move on. But thank you so much for coming tonight and going over that with us. We really appreciate it.
Thank you, Alan, and thank you, Nissi, and everyone who participated in, getting this conference organized.
Thank you.
Thank you.
I think you need to unshare your screen, or.
Okay, let me just.
Okay, thank you, Doctor.
Did it unshare now or not as yet?
I think we're good. Let me just see. Does everyone see that now?
Yep.
Yep.
Okay, thank you, Doctor.
Okay, so I'm going to leave and I'll.
All right. So our next speaker, we're going over a little bit. Hopefully that won't impact our other two speakers. They'll still, talk for 30 minutes. And then at the end, if you wanted to stick around, we can ask more questions of our last speaker. But our next speaker is Uliana-Murphy. I've worked with her many times. She's an attorney who practices exclusively in the area of special education. For the last 25 years, she's been an advocate for children with disabilities, helping families obtain the services they need in school. Angela is the mother of 3 children with disabilities. She's a frequent speaker for parents groups and on many special education topics. So welcome, Angela.
Hello, can you see me? Oh, start my video. Okay.
There we go. I'm going to stop my sharing and you can share your PowerPoint.
All right, do share screen. You think by now I would be good with this? So it's hard to try to summarize special education in 30 minutes. So I'm really not even going to try because it's actually impossible. I'm just going to toss out some key areas. And I think that these areas are even more critical that will be hopefully coming out of the COVID closures and the impact that has had on education. We know that education has been substantially disrupted for more than a year now. So as parents, I think it's critical to look at your child's IEP, your child's evaluation, your child's programming with an eye towards how different were things in 2020 and what does that look like now? So I'm going to talk about the IEP as a roadmap, and I do this frequently. So if you've heard me talk about this before, I am going to have a hopeful return to normal slant on this, because I think this information is, again, even more critical with what are we going to do in the fall. A roadmap, you want to see where am I now, where am I going, and then how am I going to get there. And the where are we now is found in the evaluations and the present levels of educational performance. And those are so critical. Accurate, up-to-date information in those present levels and in an evaluation report really will make the difference between an IEP that's appropriate and one that is just frankly awful. The where are we going are the goals and objectives. And I think we're going to have to think a lot about where are we going in the next year, because we don't want to hear, well, now my child's lost a year of education and maybe they're behind and maybe they're not, maybe there's new issues. So what are we going to do next? We have to look at that very differently, I think, for the coming school year. And how are we going to get there is contained in the rest of the IEP. The SDI, specially designed instruction, the placement, related services, etc. If I use an acronym that you're not familiar with, feel free to let me know. And I certainly don't mind questions as we move along. I guess Ellen's going to have to let me know because I don't know how to do the chat room and share screen at the same time. So evaluating your child's services, again, is going to be critical post-COVID. I'm going to say, and there's going to be a lot of people who disagree with me, for the most part, free and appropriate education has not been provided to anyone since the beginning of the school closures. Now, there are exceptions to every rule, absolutely. But overall, it's been an abject disaster with no continuity of education whatsoever. Some districts have done extremely well, no question, but others just have not. And so again, I recommend that you look at where your child was in March of 2020. What were their needs? What were their goals? Compare that to where they are now. For the most part, very, very few schools kept any data collection during the March closure last year. And they started taking data collection again this year. But again, if they were mostly virtual, many of those goals were not able to even be assessed because they might have dealt with in-person, something was needed to be done in person. And behavioral goals are the biggest example. How are you going to do a behavior plan if a child is virtual? You can't do it. You can't assess it. You simply can't do anything. So that virtual piece, again, I think is very important. If your child was mostly in virtual instruction for most of this year or parts of this year, your child was probably significantly hampered in how they receive their services. So we want to look at where the child is now, what the child needs in terms of being in person. That's what most children with special needs require. Again, there's any number of exceptions, but for the most part, people have been severely impacted this year. One of the biggest concerns that I have is watching families who now have new concerns. You had a child who had, strictly speaking, a specific learning disability in reading, and now that child has developed anxiety, school avoidance, any number of issues that now will require a new evaluation. So going back to the data collection, again, this is critical. You really can't have a good IEP unless you have good data collection. And this again is a spot where the districts can use substantially for their advantage because they're collecting the data and they want to show that the student is progressing. I've seen cases where the data doesn't even match what the student is doing. For example, with a reading goal, they may be using a grade level assessment where the student in third grade isn't even reading at a first grade level. The student's numbers, excuse me, could be going up on the data, but there's no real assessment as to where the student's actually performing. I would strongly recommend that you look at your goals and truly understand what data is being collected, how it's being collected, and make sure that you receive it regularly. Most of the schools will send it quarterly, but a lot of that quarterly data collection is just a number and one brief anecdotal statement. You need to understand this. And it is perfectly okay for you to ask for more of the data collection. A district that keeps good data is going to have the advantage in any due process proceeding. In fact, if a district taking good data has evidence of progress, that's what you want. You don't want a due process complaint. You want your child to be making progress. But most of my clients really don't understand what data is being collected and how. When they get that, some of them never even get the sheets, the goal sheets at the end of each quarter. So take a look at that, especially now. It's going to be especially critical to see how data was collected this school year. I mean, it's critical every year, don't get me wrong, but it's going to be especially critical this school year. And the reason is most of our children are behind, and they are in much worse shape than they were probably in March of 2020. So, in an example, I used the behavioral goal. You have a child with ADHD who's in attendance, but has been mostly virtual. How are you going to assess that they're keeping on task? A lot of the schools did not have requirements for the child to keep their camera on. If the camera wasn't on and the child wasn't attending, the only way you're going to be able to tell that is if the work was not completed or wasn't handed in. So again, I have not seen a lot of data collection modeled to the model of instruction. But now let's hope we're going back to in person. We are going to have to take a look at this again. There is also a tremendous inconsistency with data collection. You should be getting that every quarter. You should understand what's going on, and hopefully the data does show that your child's making progress. Excuse me. If your child has not made progress, or if you think your child is not, and in this regard, I'm going to suggest to you, you know your child better than anyone else. You may see that your child, the numbers that the district gives you says your child's making progress, but you're looking, especially after watching the virtual instruction, you're looking and saying, well, they're saying she's reading on a 3rd grade level, and she can't even read a preschool book that her younger sibling has. Follow your instincts. The biggest piece of advice and the most important piece of advice I could give parents is learn, understand the law, but follow your instincts. And if you don't think your child has made progress, I would suggest that you request an IEP meeting to discuss revisions. Are there new issues again that developed? Maybe your child is very anxious and is now refusing to do work. Maybe they didn't want to wear masks and the school was overzealous in enforcement with the masks, and now the child doesn't want to go. Or maybe now instead of just reading, there's an aversion. Math is starting to show because the math is getting more complicated. It could be anything. But if there's new issues, there's probably going to need to be more evaluation. And that's the other piece here. If your child's not making progress, do we need a new evaluation? And we'll be getting into this in the next slide, but having a good evaluation is, I think, is the most important piece of any program. And that's where I start with all of my clients. Where are we at with the evaluation? And what do we need to secure in order to work towards an appropriate program? This is providing any new private evaluations to the school district is a good idea across the board, but I think it's especially good idea for this past school year, because if you've been the primary teacher and your child's now seeing a psychologist for, again, anxiety, that's been the most prevalent. I've seen such a despairing increase in mental health between anxiety and depression that impacts work and engagement. I think that's where a lot of families are going to need to go, is ask for new evaluations to address those needs. And for the most part, you probably have been seeing a psychologist or a doctor about anxiety and depression. So don't hesitate to provide that information to the district. So here we are at the comprehensive evaluation. Always look at when was the last time your child actually had an evaluation. The timeline is 2 years for intellectual disability and 3 years for any other disability. However, you can ask for an evaluation prior to that 2 or 3 year time period. Many times I will see cases where the parents were repeatedly asked to waive the evaluation, which you can do. You can waive the evaluation, and there may be many good reasons to do that. But for the most part, I would strongly discourage waiving a reevaluation. Because for a child, we're expecting that in a 3-year period of time, we're going to see growth. And if we don't see it, even if we might see it on the numbers that the district are using in the IEP, we should pick it up on that reevaluation. I've had many, many cases where I've dealt with an older student, asked about the last evaluation, only to find out that it had been 6 years since the child had a comprehensive evaluation. Especially with the past school closure, I know the districts will not love hearing this. I think parents are really going to have to look at, do we need a new evaluation going into the next school year? Be careful when requesting that, because the districts were swamped with the COVID backup. A few districts have been either discouraging or outright refusing to do evaluations on students prior to the time that the reevaluation is due under the law. They cannot do that. If you request an evaluation, they should be saying yes. And so I don't want you to take as the answer, no, it's not due for 3 years. Wrong. You can ask for it now. And I think looking at this going into the new school year is going to be particularly important. Unfortunately, right now, if you asked tomorrow for a reevaluation, even if you signed the permission on Monday, you wouldn't have the eval anyway until the new school year. But it's going to be critical. In looking at a comprehensive evaluation, we do need to ask, were all the areas of need assessed? That's a common error, that we have a child who has ADHD and maybe some ODD and some anxiety, and yet they acknowledge the diagnoses, but they focus on the academic needs. On the other hand, there are many children, this is particularly concerning when you have a child who is solid academically, but they have autism or, again, ADHD. And I keep bringing up ADHD because I think that population was really hit hard this past school year, because many of the children I work with who have ADHD actually do well when they have structure and guidance, but they cannot, no matter what, do the virtual instruction. I actually have an adult who's finishing law school who had to do virtual, and she has ADHD, and my poor daughter struggled immensely because the virtual format's just simply not conducive to someone with attentional deficit. So that population of parents is probably going to have to look closely, because most of the time, the very bright child with ADHD is overlooked because their scores are okay. So you want an assessment that meets your child's needs. Very critically is, do you understand the evaluation and any piece of what I'm talking about? Do you understand the document? If you don't, there is certainly no harm to ask that it be explained to you, and explained to you in layman's terms. I am sad to say that most of the people that I see, they have their first explanation of the evaluation in my office. And once again, I'm not a psychologist. I've been doing this for a long time, so I understand and can explain the evaluations, but the school should be providing you that information. And if you don't understand, I would strongly encourage you to find out. Now, when behavior is an issue, and this is what's been bizarre about this school year, you have to somehow observe that behavior and figure out what's going on, but you can't do an FBA virtually. So behavior is, I think it's going to be it's always a big area of concern, but it's going to be particularly so going into next year. If your child's behavior impedes his learning or or that of others. Behavior has to be addressed in the IEP. So, you know, most of the kids, again, who are impeding their own learning are missed, because you'll get the notes that say, well, Susan is very distracted, or Susan leaves the room, or whatever, but because Susan isn't having a verbal outburst or meltdown, the behavior is missed. The FBA is based upon observation and data collection. That's not happening this year unless it's in person. And even with in person in the smaller setting, this behavioral piece has been such a mess this year. I would say to you, if the behavior and its frequency and duration are not clearly and specifically identified, it is not possible to develop an appropriate response. So you're looking for some detail here. And again, how are we getting detail right now? We're not getting detail right now. And the volatility of 1 week I'm home and another week I'm in school. So I guess I have to take the districts who have managed to be open, I have to take them out of this discussion, because hopefully they're doing this. But most of the children I work with have been hybrid, or, you know, 4 days and 1 day's off, or, you know, some schools like Allentown just went back in the middle of April. So this is still, the lack of instruction is still a chronic problem. The other thing with this is you want to make sure the district's data captures what's going on. I've had a lot of IEPs that, for example, with a child who has a meltdown, they want to measure how many times the child goes to the support room, but the child has a TSS. And the child doesn't go to the support room, the TSS manages behavior. Well, it's going to appear that the behaviors are reduced. Another big error in goals for behavior is that the number of disciplinary referrals were reduced. Well, there's nothing objective about a disciplinary referral. A compassionate, understanding administrator is not going to refer the child or discipline the child whose behaviors are a manifestation of disability, whereas a very rigid person, the child could be disciplined for everything that he does. So those are all examples. I'm not going to go much detail about the functional behavioral assessments, because that whole thing again has been a mess. But again, we want more than one observation for 20 minutes. We want it conducted through an extensive period of time. We want the behaviors accurately identified, and we want strong data collection. So we'll, again, if your child has behaviors and has had behaviors at home, monitor that particularly. One area where behaviors are missed completely is where the child has school refusal. School refusal is always put on the at the feet of the parents. I think the school refusal issue is going to increase going into next school year. And so the districts fail to see that the actual refusal to attend school is a behavior that must be addressed. And so that becomes critical. And in doing that, identifying the anxiety as a source, identifying the school phobia, going to your private professionals is all going to be very critical. Goals and objectives are also very important. And again, I strongly suggest that you take the time to really look at your IEP. And if you don't understand it, trust me, they're very complicated documents. They really are not written for the layperson. And sometimes I think you have to be an attorney who practices special ed law to actually understand it. But some ideas to look at for goals and objectives are, what is the projected outcome of the goal? Is that even clear? Sometimes it's not clear. And it should consist of what the child can be reasonably expected to progress in 1 year. And this is where parents and districts often clash, because we don't want to have a child who's behind 3 years in reading and only see them make 1-year progress. So, you know, that's a potential source of contention. The goal has to be specific, so you know what they're doing. It has to be objective, so the progress can be clearly measured. Again, a referral to a disciplinary referral is not necessarily objective. It's not, in fact, I'm going to say it's not objective, because one teacher may refer for something that another teacher will not. Does it pass the stranger test? And that's what's in the case law. The case law refers to a stranger test. And that's important. So is it understandable to anybody who would pick it up? But more importantly, do you understand it? And beware of goals that never change from year to year. That is a sign of a deficient program. Now, I breezed through that relatively quickly. Again, I'm sorry that took so long, so I'm going to stop sharing. If anybody does have questions that I'm not able to answer today, I think my information is readily available, and certainly Ellen has that. I'm going to stop sharing, Ellen.
Okay, thank you. There was one question. I guess this person, their special education people said that school district acknowledges that their son needs COVID compensatory services, but the problem going on right now is a hiring problem. We've heard that before. Yet the school calendar's ticking away and there's more lost time.
And that's an interesting question because, and I've been struggling with that with myself. I did not see anybody do COVID compensatory services analysis well at all, to be honest with you. It was, all the data turned out rather conveniently in favor of the district. But it also didn't take into consideration the ongoing disruption throughout the year. So if the determination of CCS was made by November, but most of the schools were closed from December to January, and then there was an outbreak, and then they were closed again. And so, or if the child was there 4 days a week, it wasn't for full instruction, it was 2 days of instruction and 2 days of repeating those other 2 days. So I actually think COVID compensatory services should be a concept that was related to that closure last year. Now, the regulations had changed, and then CCS, well, the guidance had changed. Then they started referring to CCS being completed when there was a full return to in-person. Now, I know of very few districts that have returned fully in person, very, very, very few. So I would look at CCS more in the nature of compensatory education, the more traditional analysis. So in this case, if your son was supposed to get CCS but didn't, that's only one piece of the equation. So now that's going to be owed. But then how was the rest of your son's program impacted? So I don't want parents to get so caught up in CCS that they forget that there was an overall denial of faith this entire school year. So I would say he's owed the CCS, but more likely than not, he's also owed compensatory education. This is very complicated. I don't think the lawyers have figured it out yet. And certainly parent lawyers and school lawyers have very, very different opinions on this. But my personal inclination in my practice has been to look at it more like a traditional compensatory education, a true denial of faith, which frankly is what it was.
Right. Well, that was the only question there was.
Okay.
So thank you so much. Always very enlightening. And if people need to figure out how to get a hold of Angela, just get a hold of me, and we can get you over with her contact information, get me that information. So thank you again.
Thank you.
I appreciate it. I was going to do a 10-minute break, but I figured we'd just go right into our next talk. And so let me just introduce our next speaker. Now, are you there? Domenico, I'm going to butcher your name, I bet. Can you say your last name for me?
Sure, it's Cavaiulo.
Cavaiulo.
I'm not Italian.
I would not have. No.
It's okay.
Why couldn't you have a simple Italian name like Bacca?
Yeah,
It's Mila. Domenico has been involved in the field of rehabilitation and special education for over 42 years at various levels. He developed a post-secondary education program for individuals with intellectual and developmental disabilities called the Career Independent Living and Learning Studies, that's CILLS, at East Stroudsburg University. For those of you who don't know, East Stroudsburg University is in the Poconos here in Pennsylvania. He is instrumental in the design and implementation of a self-determination in the lives of individuals with disabilities through employment and education. Thank you for being here this evening. And I'm going to unshare and allow you to share your PowerPoint.
Okay, thank you so much.
Thank you.
Just like Angela and Dr. Sheikh mentioned, trying to do a presentation like this in the amount of time that we have is nearly impossible, but we will do our best in getting the content to you as clearly and as quickly as possible. So what I'd like to do, though, is be able to begin by saying that although I'm going to present some data and some information related to various disabilities, but the disability of epilepsy should be taken into consideration throughout this presentation as we talk about the various aspects of transition. One of the things that really baffles me is that transition being virtual. I have a real hard time understanding how transition services can be provided appropriately and effectively in a virtual way. But I know we've tried, and to no fault of anybody within the school systems, within the school districts, they're doing their best, and I can say that with some level of earnesty. But virtual transition is not a good and effective way. The other is online, and I know that there are a lot of school districts and a lot of individuals who receive services online in terms of transition or even their education. And to me, I find it extremely challenging and difficult to think that transition can be provided to individuals with disabilities on an online basis. But again, depending on the nature of things. Now, I've dealt with many different disabilities throughout my career. Epilepsy has always been seen as a comorbid type of disorder with the various other disabilities that I work with. So the data that I'm going to represent or talk about is somewhat it should be taken into consideration, because I do believe that to the same extent, the data related to the information I'm going to be talking about, we know that there are studies that have indicated and shown that the poor outcomes of individuals with childhood epilepsy is very similar in terms of transition outcomes. I apologize. My very first slide here I can see is already has a typo, and hopefully there aren't any more typos than that. But just a little bit of a self-promotion. There is a book that I was involved with a few years ago with Dan Steer and Ernie Rose, and I'm very proud of this book. It's Transition to Adult Life for Students with Disabilities, and I think it is a very user-friendly and parent-friendly, and it's been out for a while, but I would, if you're interested, go on Amazon. You can probably get it for about $10. Anyways, a little bit of self-promotion there. And again, I'm going to move quickly through the first several slides, and then go right into some of the more important aspects of what I feel are critical to transition for this particular disorder. But I want to just talk about a couple of things first. What is the purpose of education? We know that the purpose of education is to prepare everyone for life in general, to work, to function, to participate in our society. That's the purpose for everyone. in education, and that includes those with disabilities. Now, again, we have to understand, I totally understand that individuals or students or individuals with epilepsy don't necessarily require a lot of the things perhaps that many other students with significant disabilities might require. But I think there are some very important characteristics that have to be addressed that I'm going to talk about. We know that the educational system, in terms of the expectations of students, what have we seen? We have seen poor results. And these are just some of the results that we have seen from a couple of disabilities, those with on the spectrum and those with intellectual disabilities as well. We know that 20 to 25% of adults with autism spectrum disorders are engaged in employment, which is very similar to other disabilities that we hear of. That means that 70 to 70% of the population of students with disabilities are unemployed, which we never hear about in terms of our unemployment figures in our society. Post-secondary education, only 10 to 15% of students. Now, again, I can't say that this is a similar effect of those individuals with epilepsy, but we know that this is a challenge for many individuals. And the question is, are we preparing individuals who have varying disabilities, including epilepsy, to be able to participate and function in higher education? There's an interesting data report, which is the National Longitudinal Study, National Longitudinal Transition Study 2, which is a federally funded study that was done and continues to be updated. But these are some of the things that the study, and it covers every disability or many of the disabilities that we discuss. 44% of students with disabilities, including those with ASD, do not have friends. 83% never receive phone calls from friends. And I think those of us that are parents who have children with disabilities, when you read these kind of data, it's disheartening. It's just hurts as a parent of a child with a disability. More than 50% of students with disabilities do not have, and other ASD have outcome statements of competitive. So that means that only 50% have outcome statements of employment. 15% have statements that focus on sheltered work. And again, I know that this is not something necessarily relevant to those with epilepsy, but it's important to understand that disability is a broad category, and it's important to understand these kinds of figures in relationship to the broader view of disabilities in our society. Employment, improving the quality of life, is the ultimate goal of education, and certainly employment and community inclusion is one of those things that will ultimately improve the quality of life for all of us, including our children with disabilities. So again, some of these things may or may not hit home or have relevance to the population of students with epilepsy, but there is some connection, and there are some data that does mirror some of those things. I have to apologize. I'm struggling with a cold for the last couple of days, and I'm just, struggling with it. Now, what is the definition of transition? And again, the key words here under the federal definition is that it's designed within a results-oriented process. And that term, that single word, has been changed from outcome-oriented to results-oriented. And that operative word is very important, because there is when we talk about results, we're expecting something meaningful, that it's not just an outcome that, we can put it into words, but it's really something significant and meaningful that leads to to something important for the individual student. So again, when we think of what transition is, it is a results-oriented outcome. And the definition includes these aspects. And your IEP, your child's IEP, and some of you may be in different parts of the country, but the IEP may be different in different areas, but it still contains these very important areas. Instruction, that is, how is my child going to receive instruction? Will he receive accommodations, modifications? In what form and what modality will my child best be able to receive the instruction that he or she needs in order to succeed academically and in other areas? Community experiences or community living. That is, are we preparing individuals to function and participate in our society, whether it be independent living or whether it be just accessing the community in general? Employment. Are we preparing individuals for the world of work? And that, again, includes going on to post-secondary education, going on to college, which many kids do go on to college. That is, those with epilepsy could and do oftentimes participate and go on to college. So are we preparing them for a career that will lead them to a successful outcome? And I want to talk a little bit about that in a couple of minutes. Again, areas of self-awareness and self-determination. It's important that our students and our kids have a self-awareness of their own disabilities, that they recognize that their disability is just a function of who they are. And it's sort of like just those billboards that we see in relationship to mental illness. I am not my mental illness, those billboards read. Well, it's trying to indicate that, we have to go beyond that. It is, we don't identify a person by their label. We identify them by their character. And we want them to feel comfortable and have some self-determination about who they are. So giving them a sense of awareness and understanding of themselves only leads them to a more successful self-determined life. When we talk about vocational orientation with employment, we should be really focusing on, particularly with those with epilepsy, is, are we addressing the safety issues of the type of work that my son or daughter is trying to obtain? Now, if they're going on to post-secondary education, well, then, whatever job that they're pursuing is going to be dealt with in that career path at the university level or at the college level. But again, we have to still talk about and still address the safety issue. Is my son or daughter in a type of employment that will allow them to function safely, given that they do have certain, medical conditions like epilepsy. So again, it's a matter of, are we addressing those very important critical areas when it comes to employment? Independent living, when I think about independent living with individuals with epilepsy, are we addressing the most important safety issues? And the Dr. Sheikh really presented some very interesting, information, very fascinating to hear the different types of, medical kinds of things that allow us to be more aware of our children when they have an epileptic seizure. And having that awareness helps us to respond quickly. Well, again, as our children become adults and they're out on their own, are we helping them to build an environment, their own living environment, in a way that will allow them to be safe and have a safe environment to live in and to function in? So again, these are things that, we don't always think about, and in my career and involvement with transition, I deal with so many different aspects of transition to adult life with so many different disabilities that, sometimes we have to jump out of the and I hate using, think out of the box kind of cliche, but jump out of the box and say, all right, this is a whole different type of kid. These are characteristics and nuances that, are unique to this particular individual. How do we then address these things with this particular individual? And Angela said some very interesting things with regards to assessment. Are we evaluating and assessing our children in a way that will allow us to get all of this information, that will allow us then to provide them with appropriate educational services in terms of transition that will allow them to be successful as adults. So these are the kinds of things that I think are important for all of us to keep in mind and to remember. We also have to remember that transition focuses on a student's interests and preferences. It is the individual's preferences and interests, not what we think or what the school district thinks is important or what they feel should be relevant, but what is the student's interest and preferences is what we should be addressing. So what are some key areas? And I want to move a little bit quicker. And I know that Ellen has the slides, and I'm sure she'll be able to share all of these that I'm moving along very quickly. But what's the number, what are some of the important aspects of this is that we have to plan ahead. So if your child is 16 or 14, which is when transition essentially must begin, the federal law does say that transition must begin no later than 16. But in Pennsylvania and New Jersey and many other states, they've decided that transition should begin at age 14, which I think is the better age to consider and to think about. So at the age of 14, and I know this is hard, we should be asking the question, where do I want, or where will my son or daughter be when he or she is 18, 19, 20 years of age? What is it that we're expecting them to do and to be at that age? Are they going on to post-secondary education? Are they going into a job? Are they going to live in their own apartment? I mean, these are critical questions. And I know for many of us, including myself, made a decision about where my life was headed later on. I was in my 20s and my career really didn't get established until my mid-20s practically. But it's different, with individuals with disabilities. And, we need to plan very, very early for what we're hoping to achieve with our children. One parent asked me, when does transition begin? Well, it begins in kindergarten, depending on the severity of the disability that we're addressing and needing to address. It could be as early as, kindergarten, first grade, because we're preparing children on a long-term basis and a longitudinal way. So what should the IEP process look like? What should it contain? Well, the IEP should look like this. And again, we should always look at the post-school outcomes. You as a parent must have a post-school outcome statement. I would encourage, and this is what I encourage all the parents that I work with to do, is to write an outcome statement. What is it that you are expecting your child? Where do you expect your child to be? Or where does your child expect to be when he or she leaves public school system, when they're no longer in school? And it should include vocation. It should include community living. It should include independent and community access. It should include relationships. These are things that are critically important to our children and to you as a parent. So we want to be able to identify what is it that we're planning for. It's sort of like planning for your retirement. How many of you want to, we sit there and say, well, I want to retire at age 65. Well, at age 65 how long do we plan on living, and what do I need in order to survive from that point on? And we kind of do things backwards, right? We make a statement about when we want to retire, and then we plan backwards by indicating what we need to save. Well, it's the same thing here. What's our post-school outcome? Now that leads us into taking those post-school outcomes and looking at our present levels of performance, taking a look at, as Angela was talking about, that are all those evaluations that come forward and saying these are our present levels of this individual. That is, this is where this child is at academically, performance-wise, vocation, whatever it is that we're looking at. But what is the present level of performance? Now, knowing what our post-school outcome is and knowing what our current level of performance is, what do we need to do from here on in to make sure that we're going to achieve those outcomes that we're trying to attain? That leads us into the statement of transition needs. So now we have the present levels. All right, what do we need to do in our transition statements and needs to better reach those post-school outcomes? And then that leads us to our annual goals and objectives. Now, don't get me wrong. The expectation isn't that you will be achieving those post-school outcomes in that first year. I mean, that's not the goal. But it is scaffolding. In education, we use what the term of scaffolding. That is that it's like a ladder. What do we need to achieve this year in order to move into the next year that will get us closer to the post-school outcome, that when we get to there and go to the next year, it's a scaffolding effect of activities. So every year you take a look at your previous year's goals and objectives, and they should be continuously progressing. I'm working on a case recently, and that case that I'm looking at. In the last 5 years of this child's IEP, the goals and objectives have never changed. The statements of transition have never changed. So something's wrong. If the student or if this kid's goals and objectives have never changed, well, something is wrong, because if we know that in 1 year that nothing has changed, we either need to be changing our teaching strategies because they're not working, or we need to be changing our goals to make those goals a little bit more manageable to ensure that we're meeting some success. But we shouldn't have the same level of performance or goals year after year after year. They need to be progressing. As Angela was saying to you earlier, and again, looking at it legally, and Angela and I work together a lot in situations, is taking a look at those, the goals, not the goal sheets, but the data sheets. Are we receiving data that supports the movement of students? Are we seeing the data that's showing progress with our kids from year to year? And if we're not, then there's a problem. Because quite frankly, as much as I believe that schools want to do the best and may have integrity, I'm not quite sure that it's always there. Some schools do better than others, as we all know. And it's a matter of whether we feel comfortable with our schools. So again, outcomes categories, these are the outcome categories. So an example of an outcome statement: Maria will work in the community with supports. Andre will live in an apartment with one other person with support. Brent will take courses at the community college. Again, depending on your child's needs, these have to be goals and outcome statements that are results oriented. There is a result that will be achieved at the end of this particular goal. So we have an outcome statement. So you see it up here in the outcome statement. Then we have the annual goals that are addressing aspects of this outcome statement. Again, these are the scaffold effects of the goals. And then we have the objectives, the smaller objectives, the things that we have to deal with or address to meet the goal, which ultimately will lead to the greater outcome that we are making the statement of. I know we don't have a lot of time to discuss all of this, but I'm certainly happy to respond or answer questions because again, I don't try to make this very complicated. It really isn't complicated, but understanding these particular slides like this are important to understanding how the transition process looks. So if we were to say live in an apartment is the ultimate goal, well, what does one need to do to live in an apartment? Well, they need to learn how to cook. They need to learn how to clean. So again, these are things that are contained in an evaluation. To what extent does a person know how to cook? To what extent do they know how to clean an apartment? And that's how we are able to obtain the objectives using a microwave, reading a recipe, using a vacuum, learning to dust. These are things that are relevant to the person's life, if that's the area. Now, I want you to take a moment to think about, who are the key players in the transition planning. And the key players are students and families. Self-determination and involvement in the plan is important. And when I think about self-determination, I think, particularly for individuals with epilepsy, in terms of, many students with epilepsy will go on to post-secondary education. Well, what do they need to do in terms of self-determination? Well, they need to know what their rights are. They need to know what their rights are under the Rehabilitation Act. If they need some type of accommodation, they need to know what their rights are under the Americans with Disability Act. Are they receiving some type of instruction in those particular areas that will ultimately allow them to receive some accommodation? Now, remember, I'm saying accommodation here, not a modification. And that is, completely different. One of the things that I want to think about, or one of the things that I think is very important to consider as a family when you're trying to prepare your make decisions about what you're preparing your son or daughter for. If I'm preparing my son or daughter for post-secondary education, for going on to college, I want to make sure that the courses that they're taking are not modified. That they're not modified courses, that they're not taking remedial education, because I've seen IEPs that will say that the students will attend college upon completion of their high school diploma. Well, they can receive a high school diploma based on their IEP goals, but when you think about going on to college and you think about the academic that they're receiving, if they're receiving remedial academics or they're receiving modified academics, we have to question whether our child will be prepared for post-secondary education. Are they prepared for movement into college? So as a parent, you really have to be very cognizant and be very much aware of that information, or how that information is being presented to us in the IEP. I know that we're running a few minutes late, and Ellen did say that I could go a couple of minutes late, but I promise I will not go too much longer. But again, the concept of transition is simple, and I want to go through some various steps very quickly. First, the student and family need to think about what is their life going to be like after high school, long-term range planning. Secondly, collaborate and design a high school experience that so the student gains necessary skills that reflects their strengths, their preferences, their needs, and their life goals. What are we preparing our child for? And if it's post-secondary education, then we have to look at the academics and make sure that we're preparing them. And also making sure that our child knows about how to advocate for themselves, knowing, again, their rights under the law, because every state or every university and college in this country, because of the Americans with Disability Act and the Rehabilitation Act, must comply with accommodations for students. So again, it's not modifying the curriculum, which is different. It is accommodations, providing our children with accommodations. So if your child needs extra time, if your child needs longer periods of time to prepare or to do an assignment, or to have an assignment done in an alternative modality, that's an accommodation. Doesn't change the outcome of the assignment, just changes how that assignment will be conducted and done. So it's very important that they understand these accommodations for our children. And then we have to connect our students to the post-secondary programs and supports and services that do exist. So again, quickly, steps. Explore options for the future in the areas of employment, continuing education or training, living space, and other important areas. Those are things that have to be explored. Explore them as early as possible, 14 years of age, if not, no later than 16. As a family, decide what options you think would be best for your child. Some families find things like person-centered planning. And again, we don't have time to talk about this, but I can certainly give you more information on that process. But person-centered planning allows a family to think about the future and what aspects of their child's life would be important and valuable to consider. Participate in the IEP and communicate your preferences for the future. Your child should be at the meeting. They should be participatory in the meeting. This should include outcome statements. These are things that are important. You, as a parent, should participate and must participate. If you don't understand something, as Angela was saying, make sure you raise the question, ask. And we have all kinds of acronyms. I just heard a new acronym tonight, CCS. What is it? COVID something services or COVID compensatory services. It's like, we're creating new acronyms all the time. So let's make sure that we understand and participate, and have your son or daughter advocate for themselves. Once your preferences for the future have been written as outcome statements, discuss and agree upon those annual goals and how that education will be provided to their son or daughter. At the IEP, develop an action plan, a plan of action. That's not the IEP itself, but it's, an action plan that you feel are the steps to be taken for your child. Now, that action plan can be put into the transition part of it or the goals and objectives, but it's an action plan that is agreed upon, by all members of the team, that this is what we're going to do in order to move forward in the process. After the IEP meeting, maintain communication with your school. Monitor the progress of your child. Make sure that you're getting data, that you're getting information and feedback on your child's IEP goals and the progress that he or she is making. And as your child gains additional experiences, you may need to revise the IEP and the outcome statements. There's nothing to say that, post-secondary education may not be something you consider in 1 year, but then the next year, things may change, or vice versa. These outcomes can change. Our children change their mind, and it's okay to change the outcome statements of our children's goals. And these are things that should be agreed upon and worked upon with our children. So the questions, and again, I'm going to stop there and I'm going to leave you with this. There are many questions that you could ask. And in my slides that Ellen does have, these are some of the questions that I have listed there. We know that epilepsy is a very complex disorder, as Dr. Sheikh mentioned to us, and we have to understand the complexity of this disorder as it relates to our children's future and their life after school. So let's make sure that our school is doing what it's supposed to do in preparing our children, whether it be work, community living, or going on to post-secondary education. Let's make sure that the right services are in place in order for those things to happen. We ran out of time, I know, but I really thank you for allowing me this time to talk with you. And I apologize if my raspiness has been an effect on this presentation. Thank you.
You can, I know that we're over our time and everything, but my thought was, if people need to go, they can just go. So if you want to finish, I'm fine with that.
I'd be glad to there's not a whole lot more left, but yeah, I'd be glad to, if people desire. Okay.
Yeah, I took a peek at your slides and they're just so good. I would hate for you to end early.
Okay. All right. I don't mind that, Ellen. Okay.
Thank you.
Again, are the specific outcomes based on the student's family's input? Again, these are questions, as you look at your children's transition, and let's not mistake this. There's one item here. It's the IEP. There is no transition plan. Okay. Some people talk about a transition plan. There is no such thing as a transition plan. There is an IEP plan, individual education program, and transition is part of it. So we have to make sure that transition is embedded within the IEP process. So it has to be embedded in the academic portions as well. And I think sometimes people forget that, they think about it as it's two different documents or two different, items, and it's not. It is one item, and transition is embedded within the educational program. Are they clear to us? What steps are being taken to clarify what the student wants, if there are any questions there? Are goals and objectives linked to the outcomes? Are there action steps clearly defined? Is the plan revised as information and experiences are gained? Every year, if our child is gaining some different experience from their educational, from their education, or from the experiences they're getting, whether it be community-based or otherwise, are they using that information to formulate more clear objectives for them? So there are two main functions to the transition planning process. And again, it's still within the IEP. There are activities of preparation, and then there are real life experiences. So the activities of preparation, are things like preparing for an IEP team, meeting, preparing the meeting, or even leading the meeting. Our students should be prepared, and parents, you should be prepared for an IEP meeting. You should be prepared for allowing your child, to lead the meeting. Research options for the future, evaluate those options. Even if those evaluating or those options are post-secondary education, are those post-secondary education options appropriate? Are they the type of, educational settings that are appropriate for my child with the disorders that they're, that need to be addressed? Evaluating progress toward desired outcomes. Learn to be assertive, disagree, and speak up. I teach a course on collaboration in the educational process, and it baffles my mind to see that I have to teach educators how to collaborate, how to work together, and how to essentially be respectful of parents. Not that educators are not respectful of parents, but I think sometimes educators, they don't want to hear from the families, and it's important that we do hear from the families, and it's important that families like yourselves who have children with epilepsy are assertive and are able to speak up to our teachers. The real life experiences are things like choosing courses. Again, the preparation was the things that we talked about. Now talk about real life experiences, choosing the courses that your son or daughter wants. Are they choosing? Developing a resume, for their life, applying for services if they need services, contacting sources of natural support. I have a student who is completing her degree, whose aunt is very involved in her natural support circle. And she is there to ensure that she advocates for her. Learning to describe one's own disability and learning to advocate for accommodations. And again, I think these are very important aspects to our children who have sometimes, and we used to call learning disability the hidden disorder, because oftentimes students would hide it from themselves as well as others because they weren't aware of their learning disabilities. And sometimes, disorders can be hidden because, it's not visible, but yet, some students, some individuals feel somewhat embarrassed or taken aback by it. And again, self-advocacy and is important for them to understand that's part of their characteristic, part of who they are as an individual. These are places, and again, depending on the severity, this is a slide that just simply talks about the Office of Voc Rehab and and other programs. But the most important program or office that would be relevant to individuals with epilepsy would probably be the Office of Vocational Rehabilitation, if they meet the criteria. Okay, but that would be one area or one entity that would provide them with some service, which is a vocational oriented service. And let's not forget that going on to college is a vocational preparation process. And there have been circumstances where the Office of Vocational Rehabilitation has funded individuals to go on to college to get their degrees in order for them to be employed. So that is an option. That is a possibility. It's not a guarantee, but a possibility. Best practices in transition: plan early, effective family, collaboration with the school and other agencies, community-based opportunities if they're appropriate, teaching self-determination, ongoing planning toward desired outcome, instruction in areas that are functionally relevant and necessary, and certainly continuous refinement. And that is, making sure that we're proactive in refining the revisions of our IEPs as needed. Ideas for improving IEPs: prepare yourself for the meeting, conduct person-centered planning, develop an action plan. And again, the most important thing that I find that parents should be doing is putting together an outcome statement, and maybe even, printing an outcome statement in large print and handing it out to every member of the team so they understand it is what it is that they are there for and what they're planning for your child. That's important that they be aware of that particular outcome statement. Start early, analyze your child's needs, create many experiences as possible, revise the plan as needed, and start early as possible. My final statement or final thoughts is, including students and families as active participants in the planning process requires creativity and commitment, creativity on your part and a commitment on the school's part. So being creative or vice versa, it requires a lot of that depending on the student's needs. I always say, and again, depending on the child, real choices come from real experiences, including work experiences. Are we providing internships and those kinds of experiences to our children so they can have a better understanding of what those opportunities are for them? And students' choices are at the heart of transition planning. Are we asking the students what they want? Are we making them the focal point of our meetings? Are they the heart of the transition planning process? Thank you again, a second time. Thank you, Ellen, for giving me the extra time. I hope I didn't go too much longer, and I appreciate the time. And if I can be of any assistance, actually, you can reach me at this address, and it's a little bit simpler. It's dcavaiulo@esu.edu, and I'd be glad to assist you or offer any advice or assistance to you in any way I can. Thank you so much.
Thank you so much. If you would have seen me during your presentation, I was shaking my head the whole time with all this useful. I wish I would have known you 15 years ago. There wasn't really any questions, but I think you're going to need a day off to rest your voice after all that. Oh my goodness. So I really appreciate you coming out tonight. I think that we put a survey out just a little bit ago, so people can fill that out. But we have this recorded, so I really wanted you to finish your whole presentation, and I appreciate it. I'm so glad to have met you, and I appreciate it.
Thank you, Ellen. Thank you so much.
All right. Well, I guess that's a wrap. So we'll talk to everybody soon, and thanks for coming out. And if you can reach out to me, let me know what you thought, some feedback, that would be awesome. All right. Take care, everybody.